You want to take? Okay, I'll take it. Ilayaraja, can we have a look at you? Sashi, be there.
Yes, ma'am.
Where are you? Wait. Okay, this. You can even have your slides, Sashi. First slide you can have.
First slide.
Yeah, thank you. Yes. Yeah, good. Thank you. Now already we have got 25 participants. That's good. Even before 8. I think then we can start on time.
Ma'am, we are YouTube live also.
Okay. Yeah, because this is a very common topic. Everybody wants to hear it.
Yes, ma'am.
இப்போ full gallery ஒரு picture எடுத்துக்கிறீங்களா சுப்பு?
Sure, ma'am.
Okay, அந்த participants வச்சு ஒன்னு எடுத்துக்கோங்க.
Yes, ma'am. எடுத்தாச்சு.
சுஷி, உங்களுக்கு net connectivity நல்லா இருக்குதுல்ல? Because I heard you are traveling.
Yes, ma'am. I am not in Chennai, but the current net connectivity is good, ma'am.
Is good only, no? Okay.
Yes,
Okay. We just restrict ourselves to 30 minutes, Sushi. Huh?
Yes, ma'am. Sure, ma'am. Sure.
Thank you.
Ma'am, should we turn off our cameras?
Yeah, 1 more minute. We'll wait. Nisha?
Okay. Sure.
You can bring Dr. Sashi's slide, Nisha.
Should I do that? Then I'll share screen.
Yes, we can. Shall we start, Subbu? Yeah, we can start.
Okay.
Yes, ma'am. Please start.
Good afternoon, everyone. Good evening, sorry. Good night, everyone. Welcome to the 8th session of Perspectives for Pediatric Postgraduates, Decoding Diseases. So, for the last few years, we've been having online sessions for pediatric postgraduates from IAP's Chennai City branch. This year, the theme is Decoding Diseases. And this is the 8th session. We come to a very important session on fluid management in children and how to do fluid management in children. And we have two excellent speakers, Dr. Sashidharan and Dr. Priyavardhini, both intensivists and both looking forward to hearing them speak about their different topics. So we'll start with Dr. Sashidharan. Dr. Sashidharan, it's a great honor to have you speak on our session today. Dr. Sashidharan is head of the pediatric ICU in Mehta Children's Hospital. He has a varied number of interests. He is, as you can see from his introductory slide, and extensively qualified. His special areas of interest are pediatric critical care, acute care nephrology, and stem cell transplantation. Today, he's going to speak to us about the very basic thing that we all, from postgraduate times onwards, we need to know, how to get the basics right of maintenance fluids in children. I worked with Dr. Sashidharan for a few years, and he's also an excellent human being. So looking forward to hearing you, Dr. Sashidharan. Without much further ado, we'll go ahead.
Thank you, madam. I sincerely thank IAP Chennai City branch for giving this opportunity. I think choosing the topic, that is the most important first step. So choosing the question is the most important first step. So next 30 minutes, we are going to discuss about few questions related to getting the basics right in maintenance fluid therapy. So next 30 minutes, we may not be able to discuss everything. So Dr. Priyavardhini will discuss about the specific disease-related fluid therapy. So I am going to discuss only on these 6 questions. Maintenance fluid therapy, how much fluid, how much electrolyte. Enteral versus parenteral fluid therapy. Always there is a myth that whenever a child is getting hospitalized, enteral becomes inferior, parenteral fluid becomes superior. That's not the case. So we will discuss a little bit about it. If we select IV fluid, how much to start with? How do we decide a post-resuscitation IV maintenance fluid therapy? I can say this is one of the major area of development in last decade. How to decide IV maintenance fluid therapy in obese children is a common problem we face nowadays. Accounting for obligatory fluids. This is a new terminology for many people, obligatory fluids. I'll try to introduce this terminology and say about some of its applications. So maintenance fluid therapy, how much is really needed? This is something like we literally want to know. There are multiple ways in which it has been calculated. Now we go back to 1957, where Holliday and Sager made some physiological assumptions and calculated the maintenance fluid requirement. So one assumption what they made is energy expenditure is equivalent to fluid expenditure. Till now, we do not, after 70 years, we do not question about this assumption. This assumption relatively remains clear, and it is still remained as a truth. Energy expenditure is equivalent to fluid expenditure. Second assumption, which is quite critical, we will discuss further about it. Energy expenditure, fluid expenditure, both are constants. This is getting questions. We will discuss further about that. So when you take a model of a 10 kg body weight child, per kg, when you say energy expenditure, it is nothing but a caloric expenditure. How the calorie expenditure happens is every kg, 100 kilocalorie expenditure happens. For a 10 kg child, the caloric expenditure or caloric need, we will say that as 1,000 kilocalorie because 100 kilocalorie per kg. It happens through metabolism. When there is a metabolism, there is a heat component and solute component which is getting generated. Heat has to dissipate from the body. So if the heat dissipates from the body without causing any injury to the physiological mechanism, it has to happen as a fluid loss through skin and respiratory tract. That should be 50% of the total component. For 100 ml, we say it's 50 ml. Then comes the solute. When the solute is made through the metabolism, in the routine conditions, we consider that negligible amount of solute will be excreted through skin and respiratory tract fluid. So predominant is going to go through the urine. So this 100% solute excretion happens through the urine. As per the kidney function, if it remains as an average normal kidney function, then average concentrating ability, the urine amount for this has to be 66.7 ml based on physiological calculation. During the oxidative metabolism, there is something called fluid gain, which is going to happen, which is around 16.7 ml. So negating that 16.7 ml, we get the product of 100 ml. So every 100 kilocalorie caloric expenditure, the fluid loss is 100 ml. This is how Holliday-Sager formula derived up to 10 kg, 100 ml per kg. This is the basic which we need to understand further. So now we go into the specific. What is the water component? What is the electrolyte component? What is the water component? I already told for kg per kg. So that's why I have clearly given you ml. Now I am going for up to 35 kg in a child. So from 1 kg to 35 kg, now we have to tell it in proportions. So the fluid loss, which is going to happen through skin and respiratory tract, is considered 50%. Urine is considered 50%. So the maintenance fluid required to replenish the anticipated loss, 50 plus 50 will become the 100% of the maintenance fluid. Again, it is equivalent to 100 ml per kg up to 10 kg. Now you go to the electrolyte component. We have only 2 components of maintenance fluid. So coming to the electrolyte component, it is again calculated based on few assumptions. One is about the urine concentrating capacity if the kidney is functioning normally. Assumption number 1. Assumption number 2 is what is the electrolyte component which is available, or electrolyte concentration which is available in the human milk formula. Human milk, not formula, human milk. Based on these two, they made some derivations. Based on that, the sodium is 3 milliequivalent per kg. That is the requirement, physiological requirement. Chloride is 2 milliequivalent per kg. That is the physiological requirement. Potassium is 2 milliequivalent per kg. That is the physiological requirement. This is how in 1957, this derivation has happened. Now we come to the conflict signal. The conflict signal is Holiday-Sager's second assumption I told you. Energy expenditure was considered to be a constant. Fluid expenditure was considered to be a constant in a hospitalized child. Okay, to an extent, it will happen in a hospitalized well child. So why well children are going to get hospitalized? It's not going to happen. Sick children and very sick children are going to be getting hospitalized. And the critical care is going to happen in a controlled environment. When you say controlled environment, there are two things are controlled. Environmental temperature is controlled, environmental humidification is controlled. And again, the therapy is controlled. What is the therapy which is controlled? Oxygen is going to be given as a humidified oxygen. So all these components are going to reduce the heat loss. So the heat loss is going to reduce. So this is the negative signal. So heat loss is going to reduce, energy expenditure is going to reduce. So what is going to happen is through the skin and respiratory tract, the whatever fluid is going to get lost from the body, that is also going to get reduced. Now we come to the third important issue, which is going to happen in and around the kidney, is aberrant vasopressin effect. This is a terminology commonly used by the critical care specialist. What is the other common terminology? ADH secretion, syndrome of inappropriate ADH secretion, SAADH. So there are many conditions in critical illness where the inappropriate ADH secretion happens. ADH is nothing but antidiuretic hormone. So it means the urine output is going to get curtailed. So urine output is going to come down to 20 to 30%. This is another major issue. So because of these three issues, we understood that there are many things are going to happen, and it is better for us to understand this and account this for the fluid therapy. This is what we understood. So there are many constants which has been taught by Holiday and Sager are not going to be constant anymore. So with this understanding, we'll try to answer the question 2. Before answering the question 2, we go to a case scenario. 5-month-old male child weighing 5.5 kg, acute bronchiolitis, viral yield is also there, RSV and metapneumovirus positive. Child has been started on high flow nasal cannula oxygen at appropriate 10 liters. NG and ND tube in situ. On day 1 of PICU stay, urine output is 1.5 ml per kg per hour. You see that it is usually Holiday-Sager rule is 150-20 or 4-1 ml per kg per hour. So here the urine output is not 4 ml per kg per hour, it is only 1.5 ml per kg per hour. This is what we call it as aberrant vasopressin effect, aberrant inappropriate antidiuretic hormone, all this which happens in a critically ill child very commonly. This is a simple pneumonia, still it happens. Other organ function status are normal. 2D echo has been done for screening, and that is also normal. So now we come to enteral versus parenteral fluid therapy. This is a classic child where we all consider enteral fluid can be given. So whether our thought process is wrong, this is what we are trying to answer in next 2 slides. Enteral intake of fluids and feeds are considered physiological. When the human being have been evolved, basically we do not have a methodology physiologically to receive fluid through the parenteral route. There is no intravenous fluid therapy physiological. So it is a completely unphysiological method. It is a therapeutic modality. Otherwise, the physiological method is enterally intake, taking fluids and feeds. Regulatory drinking, this is very much intricate and related to the critical illness stabilization or homeostasis, or what we call it as water homeostasis in ill state. So this regulatory drinking is completely related to few components, that is instructor component, executor component, and modes of maintenance. You see the instructor, it is a central signal. Okay, so the central signal is going to come from the hypothalamic area, and executor signal is executed by the kidney, and modes of maintenance are regulatory thirst and urine output. So none of these are sensitive to parenteral fluid. Physiologically, they are not very sensitive, They're not completely insensitive, but they are very less sensitive. So that is why the regulatory drinking is getting completely delinked when you are predominantly giving a IV fluid therapy. So this is one mistake which eventually happens by starting a parenteral fluid therapy. So that is why we consider enteral fluid therapy is always considered superior. IV fluid administration, we go a little bit into historical review to understand a little bit deeper. IV fluid administration was started in the cholera pandemic in 1831. First IV fluid therapy was not as maintenance fluid therapy. It started as a resuscitative fluid therapy in 1832. And then they considered that time itself, they understood that there are many problems with intravenous fluid therapy. Not only about the administration methodology, there are some physiologies which are happening, which they were not able to understand. The recovery was not something great. So you see the lag period, it is not getting established as a great therapy. Then there is something called intraperitoneal fluid therapy. And they thought that this may be a better method than intravenous fluid therapy. That is in 1918. After all this happened, then only the 1957 comes. Some parenteral fluid therapy calculation has been done by Holiday Sager. And after that, for 60 years without questioning, we started following that. So always we need to understand that parenteral fluid can never be superior to enteral fluid therapy. In other way, in a sick child, if the child is admissible for taking enteral fluid is always considered superior. This is very important. Another reason, there are many uncertainties in and around the IV fluid therapy. So what is the uncertainty? How long, when we administer IV fluid in the intravascular compartment, how long it is going to stay in the intravascular compartment? Maximum redistribution time, people say based on the physiological experiment, starting from 30 minutes to 45 minutes. So it means that how it is going to get redistributed. Redistribution in the disease state can be completely different from the wellness state. Redistribution in children can be completely different from redistribution in adults. Dynamicity of fluid movement and factors influencing this, all these carries a big meaning here. Disease-specific variation, yes, it is going to add on. Post-specific variation, whether immunocompetent, immunocompromised, post-transplant, this is also going to add. So there are many uncertainties, not one uncertainty of physiological variation which is going to happen. There are many more uncertainties which are associated with the IV fluid therapy. So by principle, we have to consider IV fluid as a drug, and we have to decide for an index child. Index child means the child whom we are treating, that specific child, what is the choice of IV fluid, what is the dose of IV fluid. This is how we have to decide. So now we come to first choice of IV fluid therapy. There are many guidelines which have evolved over time. There is a very recent guideline which is quite useful for us to decide what is the choice of IV fluid therapy. So this guidelines is ESNIC guideline 2022. It can be freely downloadable. It is, I should say, this is basically a consensus-based guideline. Wherever there is no adequate evidence or high quality evidence is available, they pulled the data from adult and they made a Delphi method concurrence in consensus conference, and then they have tried to give some guidelines. So isotonic maintenance fluid, number one, isotonic maintenance fluid to be considered to reduce the risk of healthcare associated hyponatremia. So there is no question whether we can use isolate P or not. So only isotonic maintenance IV fluid has to be used. That's crystal clear now. Balanced fluids solutions favored to other IV fluid. Balanced solution means they are very much mimicking the plasma. We'll discuss later. Avoid lactate buffer solution when there is a severe liver dysfunction. If a patient has having a severe liver dysfunction, when if you want to use ringer lactate, try to avoid that because it is a lactate-based balanced salt solution that can be avoided. A glucose provision in IV fluid to be titrated based on the blood glucose level. Routine supplementation of vitamin and trace elements are not suggested. Routine supplementation of calcium, magnesium, phosphate, not recommended. Potassium supplementation is guided by the serum potassium values. 2 points to reiterate. Balanced solution favored to other IV fluids. This is the recommendation from the ESNIC guidelines 2022. I should say that it is not backed up currently by huge evidence. Rather, it is a kind of a consensus. Okay. So if you are not having balanced salt solution, do not think too much. You can still give the other solution, which are isotonic solution, like 5% dextrose containing normal saline solution. This is a DNS, which can be very much easily used, and because it is easily available and it is cost effective also. Second point to reiterate is lactate buffer solution. You try to avoid whenever there is a severe liver dysfunction. If there is only 3 times, 4 times a transaminase elevation, do you really need to avoid ringer lactate? There is no such evidence at all. But there is a severe liver dysfunction with INR, which is abnormal. Bilirubin is quite high. Transaminases are thousands. So obviously, you try to avoid the lactate-based buffer solution because lactate metabolism is getting hampered in a child with such a significant liver synthetic dysfunction. Now we have to discuss about IV fluids and its comparison to other plasma constituents. We have told something about balanced fluid. So what is balanced fluid? This is a very important question to answer. Balanced fluid means the fluid which is mimicking the plasma constituents. That is very simple. So you see here balanced crystalloid. What is the major constituent? Sodium is 140, chloride is 98. You see the plasma here 140 and 100. So it mimics the plasma very closely. That is why it is called balanced salt solution. Now you come to this side. Yeah, this is also mimicking to an extent 130, 140, 109, 100. Yes. But this is also similar to a balanced salt solution, maybe a poor man's balanced salt solution, which is Ringer's lactate. So only problem which we can say is it is a predominantly lactate containing solution, cannot be used in severe liver synthetic dysfunction. Other way around, in all other conditions, you may considerably use Ringer's lactate if you really wish to use a balanced salt solution of low cost. Coming back to 0.9% saline or the so-called normal saline, there are many reviews saying that some normal saline is normal. It is an abnormal saline because we have 154 milliequivalents of sodium per liter and 154 milliequivalents of chloride. This is made for the purpose of creating a stable molar solution. Because of the chemical equivalence, to make a basic stable molar solution, we made the 154 combination. Otherwise, this chloride of 154 is not backed up by good physiological basis, because in plasma it is only 100. So this hyperchloremia has a tendency to create issue, especially in critically ill children. We consider that as called hyperchloremic metabolic acidosis, which may be indicated in AKI. That is why we have started restricting this 0.9% saline. Now go to the dosing in fluid therapy. Dosing in fluid therapy, maintenance fluid should be just adequate to replenish anticipated loss from the basal metabolism. Isotonic fluid with appropriate electrolyte composition has to be used. Deficit replacement, replace to just adequate level. Again, deficit replacement also should not be overwhelming. Fast correction is accepted only in hypotensive children. That too, the studies of 20 minutes versus 45 minutes, there is no big difference. So 45 minutes is quite okay. So the 20 minutes fast correction is accepted only in children with refractory shock or hypotensive shock. Titrate fluid based on the achieved response, not based on the fluid requirement otherwise. So achieved response, the targeted goals are achieved, then only we can give further fluid. Replacement of ongoing loss, measure and replace. This is very, very important. So very important thing is over the time we understood that volume sodium chloride overload, not only fluid overload, electrolyte overload also may occur due to inappropriate maintenance fluid also. Previously, we used to discuss this only based on resuscitative fluids. Now we start discussing that based on the maintenance fluid also. So the dosing is very important. Type of fluid is important. Dose of fluid is also important. Now, what is the empirical guideline? We discuss about the theory. What is the empirical guideline? So the maintenance fluid can be reduced to 60% or 50 to 70% of Holiday Sager's estimated volume in critically ill children who are admitted. Isotonic 5% dextrose containing fluid is a reasonable starting point. Further restrict or liberalize based on the specific disease status. Transition to enteral fluid, enteral feed as early as possible. This is very, very important. Titration based on further fluid and need and response. This is another important step. The isotonic fluid and IV fluid, which mimics to plasma constituents, are considered kidney friendly. So if you have any kind of kidney injury, you try to go towards the plasmalite or sterophendine like kind of a balanced salt solution if it is available to you. So now we have given an empirical start point. If you want a tabular form, so which you find it more comfortable, this is the one which has been published by Dr. Sophia Skelet from Great Ormond Street Hospital. And this is published in a book chapter. It is not an article. So I've just given that table alone here. So less than 10 kg, 10 to 20 kg, more than 20 kg, just a Holiday Sager calculation here it is given. Active and hospitalized children, you can give 100% maintenance, there is no problem. Sick and not intubated, then this 100 is curtailed to 50, this 50 is curtailed to 30, this 20 remains as 20. So this is the amount we give. So sick intubated children, so you see there is a huge change. 35 ml to begin with. Instead of 100, 35, and 30 becomes 20, means 50 becomes 20, and then here it is only 12.5 ml. So there is a significant reduction happens in the sick child, whether the child is intubated or not intubated in both scenarios. So the crux of the story is, if the child is sick, hospitalized child, obviously the holiday sager will end up in giving too much of fluid. Now we go to the next concept. A 10-year-old child, severe dengue, on day 5 presenting with hypotensive shock, transaminitis is there, lactate is high, platelet count is low, no evidence of overt bleed or skin bleed. Here we try to discuss about resuscitative fluid little bit and more about post-resuscitation fluid. So IV resuscitation fluid in critically ill children, you know that isotonic crystalloids are preferred, colloids, no consistent benefits, balanced solution only when large volume fluid resuscitation is needed. In adult, the cutoff is more than 2 liters, but pediatric, there is no cutoff. But if you require maybe more than 30 or 40 ml per kg of resuscitation, you can consider using. Otherwise, first bolus, second bolus, balanced salt solution, there is no great advantage. There is something like how to dose the resuscitation fluid. Empirically, we already told 10 to 20 ml per kg. And there is something called ROSE concept, which is a nice to read concept. You can go and read what is the resuscitation phase, what is the organ dysfunction state, what is the stabilization phase, what is the evacuation phase, and how do we decide fluid therapy in this. Understanding this is very important to decide about post-resuscitation fluid therapy. So the dose of resuscitation fluid is not only based on the BP, it is based on whether the hypotensive shock is present or not, lung is wet or dry, whether the child is having preload recruitable stroke index or not, whether the fluid response is sustained or ill sustained, and endothelial glycocalyx integrity is maintained or lost. This is very, very important. For example, in all your dengue patients, endothelial glycocalyx integrity in a critical phase is not maintained. Okay, so that is why the dosing becomes quite different. So these two components are very important to be reiterated. Sustained or ill-sustained fluid response. Again and again going back to shock. Giving fluid further is not of any use. Nowadays, we consider early initiation of inotropic agents. Endothelial glycocalyx integrity maintenance, whether it is maintaining or not maintaining, there are no clear tests or bedside tests available. The third spacing itself is a very good clinical tool to identify that there is an endothelial leakage. Now, the dose of IV fluid, there is a very good methodology which we try to follow in critical care. So initially, initially we used to think that whether the fluid is effective in the index child. Now we started thinking whether it exhibits any adverse effects. So what are the adverse effects, how it can be monitored? That's what is given here. Whether the lung edema increases. By ultrasound B lines, you can consider understanding that PF ratio will help you. Was hemodilution significant? Hematocrit will help you, but this may not help in dengue scenario. Did the RV function deteriorate? Echocardiography may help you. Did the intra-abdominal pressure increase? IAP may help you. So whenever you are doing fluid resuscitation, try to do fluid resuscitation effectively without creating adverse events associated with fluid resuscitation. This is the concept. So how to do this practically? You should know something like FO percentage. It is very easy to calculate and it has a huge meaning in pediatric population. This is one of the review article which is saying that there is a 6% increase in odds of mortality for every 1% FO increase. So every 1% FO increase, there is going to be a 6% increase in mortality, which is quite significant. FO increases in hospital mortality with the odds of 4.34, almost fourfold increase. That is quite significant. So that is why we take that as one of the monitoring parameters. So what are all the other monitoring parameters to decide about the post-resuscitation fluid therapy? You have to see whether there is any third space leak. What is the natural history of the primary disease? If you have organ dysfunction score, use the organ dysfunction score. If you have a straight leg rising test or IVC collapsibility index or pulse pressure variability or stroke volume variability, any preload responsiveness assessment test, if you have access to, please do use that. Use liberally 2D echo, use liberally lung ultrasound. Based on that, you decide about post-resuscitation fluid therapy. It means that after resuscitation, always every child doesn't require 100% maintenance fluid. This is what indirectly we are trying to tell. And every day on day, if there is a cumulative FO % more than 5%, you have to curtail fluid again. The day one is okay because you would have given quite a significant amount of resuscitation fluid. But otherwise, if it goes beyond 5%, it looks like it is an independent component to show that there is a bad prognosis. Now, how to do it in obese children? So this is another very important question. Most of the time people ask this question, there is no clear-cut answer. This is one of the table. This is a nice guideline for adults. It is a very old table, but it is useful now also. We have taken this data from adult guidelines. Why? Because the adult guideline starts from 35 kg. Whatever pediatric calculation we do, that is all acceptable till 35 kg. Beyond that, we will get we may not get the right way of calculation. So that is why you take this table and apply this. So how do we do that? Understand the standard adult guidelines. This is the standard adult guidelines. Try to match the actual body weight to the chart. Whatever be the actual body weight of the patient, try to match it to the chart. Keep this fluid requirement as an empirical start point and the titrate based on the needs and urine output trend. This is what we request everyone to do. Now we are coming to the last question. Account the obligatory fluid. So what is obligatory? What is obligatory fluid? That is what we want to understand. Whenever we are prescribing fluid to a patient, there are two types of fluid. One is called discretionary fluids, parenteral fluid, parenteral feed, enteral fluids, blood products. All these are discretionary fluids. Then what is obligatory fluid? Which is getting into the patient unaccountably. So this is what is called obligatory fluid. Antibiotic, diluents, ulcer prophylaxis, sedation, analgesic infusion, some bolus in between has been given, vasoactive agent infusion, antipyretic, electrolytes, flushes, all these are obligatory fluid. This is not negligible based on adult as well. Some very, very little data available from pediatric, but in pediatric cardiac surgery, the data which is available says that may be more important than adult practice. And what I have given here is the adult data. Hidden obligatory fluid intake in critical care patient, even in the adult patient, it becomes quite significant over time. So that is the thing which we need to understand. This is the last slide. So after this much discussion, we come to a concept which is called fluid stewardship. You know what is antibiotic stewardship. You have started hearing now for recent 2 years about diagnostic stewardship. We should not do unnecessary investigation. There is another component called fluid stewardship. So it starts with 4D principle. You follow this drug dosing duration de-escalation principle. So use it as a drug. This is what is very important. When you use it as a drug, you dose it. You have to understand the duration. You have to understand de-escalation or de-escalation. Either here de-escalation means fluid removal. De-escalation here conventionally how we can apply is switching from parenteral to enteral fluid therapy. That is also a kind of de-escalation. Fluid stewardship, these are all the components very important. Resuscitation fluids, the volume has become smaller over time. IV maintenance fluids, 60% versus 100%. This is what you need to understand. Right fluid type for each indication. This is very important. Ringer's lactate is not an inferior fluid. Please do understand. Restrict the obligatory fluids. Most of the time, this is doable. FO person plus adjunct measures of monitoring, like lung ultrasound to look for B lines. Bedside ultrasound is available everywhere nowadays. Enteral FO person and parenteral FO person. This is very, very important. So enteral fluid overload doesn't behave very bad to the patient unless and otherwise the patient is having congestive cardiac failure, chronic liver failure, something like that. But parenteral fluid overload percentage behaves bad for every patient. So that is why parenteral fluid overload percentage is very, very important. Yearly switch to enteral feeds have to be always to be promoted. Perioperative fluid plan has to be done maybe during the intra period itself, whenever it is feasible. I didn't consider discussing that because it's considered as one of the special scenario. Thank you, everyone.
Thank you very much, Dr. Sashidharan. That was an excellent talk, and we'll keep the questions. Everybody, please enter your questions that you have in the chat box. We'll do the questions at the end of both the sessions. Thank you very much, Dr. Sashidharan. We'll go ahead with Dr. Priyavardhani's talk. Dr. Priya, you may share your slide. Dr. Priyavardhani is a member of our IAP CCB, EB member of IAP CCB. She's a senior consultant and PICU and post-op cardiac ICU in Apollo Children's Hospital in Chennai. She comes to speak to us about fluid in special situations. So Dr. Priyavardhini did her MD Pediatrics at IPNB and a fellowship in pediatric intensive care, and also a fellowship in pediatric critical care in Birmingham Children's Hospital in the UK. She has special areas of interest in cardiac intensive care, infectious diseases, quality control, trauma, and neurocritical care. Again, a lovely human being to work with. We worked together closely in IAP CCB over the past year. Over to you, Dr. Priya. Looking forward to listening to your talk.
Thank you very much. At the outset, I would like to thank IAP Chennai City Branch, the President, Secretary, and Treasurer, and the entire team for accommodating me as a speaker in this program. So my topic is on Beyond Basics, Fluids and Special Situations. And we can't obviously cover everything in detail. So I'm just going to touch upon a fluid aspect alone in most of these situations that I have put up here. So DKA, dengue, burns, AKI, a few respiratory, cardiac, and neuro issues, and some miscellaneous issues as well. So first is DKA. We all know the diagnosis of DKA is with hyperglycemia, venous pH of 7.3 or bicarb of less than 18, ketonemia or ketonuria, which is moderate to large. So, and the severity classification is based on mild, moderate, or severe. It's based on the pH 7.3, 7.2, 7.1, or the bicarb of 18, 10, and 5. So this is just the basics for us to work on. So we all know that ECF volume deficit is always present in DKA to varying degrees. So how do we know those volume deficits, whether it is present or not? Clinical estimates like your physical examination findings, vital signs are going to be inaccurate. Can I rely on sodium? It is again unreliable because there's a lot of osmotic shifts due to hyperglycemia. So which is the most reliable of all the things which is available? So it's our urea, nitrogen, and anion gap or low pH at presentation, which is most strongly correlated with the volume deficit. Therefore, we use in mild DKA where the pH is 7.3 and below, a 5% dehydration. In moderate DKA, 7% dehydration. And in severe DKA, 10% dehydration. So if there's more than 10% dehydration, most probably there will be features of shock. So initial resuscitation phase, volume depleted, but they are not in shock. But they are not in shock. Start fluid resuscitation with 0.9% saline, which is 10 to 20 ml per kg infused over 20 to 30 minutes. This is based on the ISPA 2022 guidelines. And for children with DKA and shock, you're going to give 20 ml per kg boluses of 0.9% saline as quickly as possible and reassess between boluses and use crystalloids, not colloids. This is the basic initial resuscitative fluids. This may be slightly different from BSPD guidelines, but if you look at varying guidelines, somewhere it will even out based on how much we give subsequently. So it's okay to follow one guideline and titrate accordingly. So after the initial resuscitative phase, we need to rehydrate the patient subsequently, where we need to give the deficit, which has been lost already, and the regular maintenance requirements. So already we talked about deficit assumption. In mild DKA, it's 5%, moderate 7%, and severe DKA, 10%. Maintenance fluids is based on the holiday cigar formula, which we are all familiar with. So what's the type of fluid that we are going to give? We are going to give 0.5 to 0.9% saline, or a balanced salt solution, which may include an RL or plasmolite. So we have a lot of options here, but we shouldn't go outside these options. That is important, but we can work within this range. Here, the focus is on dehydration correction rather than the type of fluids. So why this is, now we have this de-emphasis on the type of fluids is because of late, people have discovered that the cerebral edema linked to DKA is related to hypoperfusion and inflammation, which is related to DKA per se, rather than the fluid rate or the type that you have given. So we are free to use within this range and within the rates that we have been recommended. So apart from the initial fluid, what are the additional requirements? We are going to give potassium supplementation either as KCl or potassium phosphate, because children with DKA have total body potassium deficits. So starting concentration will be 40 millimoles per liter. And you need to start it unless there is evidence of renal failure. If somebody is hyperkalemic, watch out if there is urine output and then start potassium replacement therapy. Then comes your question of duration of correction. Replace the estimated fluid deficit minus the initial fluid bolus which you have given over a period of 24 to 48 hours. When do I start insulin? At least 1 hour after initiation of IV fluid treatment. So we saw resuscitative fluids first, which are boluses. Then subsequently, we gave deficit plus maintenance over a period of 24 to 48 hours as 0.5 to 0.9% saline or RL or balanced salt solution with added potassium. And we are going to give it over 24 to 48 hours. And we are going to start insulin only after 1 hour after initiation of IV fluid therapy. So this is for the postgraduates. If you have a 12 kg child with severe decay and shock who has been resuscitated with 20 ml per kg fluids, how are you going to determine your initial volume of deficit plus maintenance fluids? Just give it a thought for a moment before I move on. So we have a 12 kg child. He has gotten 20 ml per kg, which means 240 ml as initial resuscitative fluid. I'm talking about the subsequent deficit plus maintenance. So assuming it's severe decay, so it's a 10% dehydration correction you need to give over 48 hours, which is 100 ml per kg, which is 1200 ml. And in that, we are subtracting the resuscitation fluid, which is 240 ml, which works out to 960 ml over 48 hours, which means that's 20 ml per hour. For a 12 kg child, your regular maintenance fluid based on holiday cigar is 44 ml per hour. So the total fluid per hour is 64 ml per hour. Okay, so that's the volume and rate over 48 hours. What's the type of fluid? 0.9% saline with KCl, 40 millimoles per liter. Insulin, I would start 1 hour later at 0.05 to 0.1 units per kg per hour, which is 0.6 to 1.2 units per hour. So having started, how am I going to monitor whether what I am doing is working or not? So I need to assess the patient very frequently, the circulatory status, the fluid balance. But more than all that, I need to look at trends in serum sodium levels, the pH, bicarb, anion gap, and ketones. And most importantly, the GCS of the patient very frequently, which means almost every hour we need to monitor. So why so? So just a little bit of physiology here. So this is a patient with DKA. There's a lot of glucose in your intravascular compartment. He has no insulin or insulin resistance. So the potassium is not getting into the cells. And this glucose is dragging the water from the intracellular compartment outward and also dragging, it's called solvent drag. It's also dragging the potassium. So your potassium may be relatively looking normal or even high, though there is a depletion of total body potassium. And because there's a lot of water drag into the intravascular compartment because of hyperglycemia, you're going to have a dilutional hyponatremia component. So the corollary is, as I am treating, if my glucose levels go down, my measured sodium levels should go up. That is the most important thing that I'm looking for. So sodium in decay is the most important thing to measure, and measured sodium is unreliable to begin with. And we are looking at corrected sodium, which represents the expected serum sodium concentration in the absence of hyperglycemia. Meaning, if there were no hyperglycemia, what would have been my sodium, which means it's likely to be higher than what you have measured. So here in a patient, we'll just look at it. As you have decay, as the sugar levels goes up, your osmolality goes up, your measured serum sodium comes down, and your corrected serum sodium remains the same because you're correcting for the glucose. So the corollary is, as you are treating, your measured serum sodium should increase, your corrected serum sodium should remain the same, and osmolarity should come down. So that is what we are looking at. So if there is an inadequate rise of sodium, that is, I expect it to be here, but I'm here, or it's falling backward, then it means I'm hydrating in excess or I have decreased tonicity of fluid. So I will relook into my fluid rates. I would also relook into the percentage of sodium that my IV fluids have. Suppose I'm in 0.45, I may prefer to change it to 0.9% saline. So few practical points. So many times my fellows come and ask, the fluid balance is like 400 negative. Should I replace it? No, don't do that because you're hydrating enough and these urinary losses should not be routinely added to calculation of replacement fluid. It usually evens out later. In obese children, what do I do? Should I use ideal body weight like how we do for dengue patients? No, no need for using ideal body weight. Suppose your fluid calculations exceed that of adult protocol, then use the adult decay protocol, which is a 1 liter maximum per bolus and 500 ml per hour as a fluid infusion. No need to calculate the ideal body weight. How do I treat or prevent hyperchloremic metabolic acidosis? Like Dr. Sashidharan said, because we are giving a large volume resuscitation here, if we are tending to use normal saline, we have a lot of chloride in it. And so you may have acidosis, the hyperchloremic acidosis. So the problem here is that your pH may not get corrected for a long time, and you may unnecessarily continue your therapy with insulin and fluids. So more important is to look at the calculation of anion gap, or you may have to look at the beta hydroxy bitrate levels, which most of us do not have. So is it really omnious here? No, not really. It will resolve spontaneously, but you're having difficulty getting the patient out of ICU. Yes, you can switch over to some fluids which are less than chloride, like your Ringer's lactate or plasmolite. So even electively, that's why sometimes we do tend to use Ringer's lactate or plasmolite. And the other important component which we all forget is the KCl that we add to the main deficit and replacement fluid. So that also has got a chloride load. Sometimes so to prevent hyperchloremia, you could use potassium phosphate rather than potassium chloride. So that's about DKA. So we talked about the fluids, the potassium, how to monitor, and some few practical points. So moving on to the next thing, fluid therapy in dengue. So this is a very, very familiar diagram for all of us. Dengue has the febrile phase, critical phase, recovery phase, and critical phase is where there is capillary leak and shock, bleeding, or organ impairment, which are features of severe dengue happens. So the pathogenesis primarily is a capillary leak, and that is what we are going to look at today. So classification by severity, how do we classify dengue without warning signs, with warning signs, and severe dengue? So dengue without warning signs, we all know it's like a stable patient. Warning signs are abdominal pain, vomiting, mucosal bleed, septomegaly, all those things. And severe dengue is plasma leak, severe bleeding, or severe organ impairment. So I'm going to stick to only fluid in the initial phase. So how am I going to manage dengue with no warning signs? Here, enteral hydration is enough. Electrolyte containing fluids like ORS or soups or kanji are good rather than plain water or a lot of sugar containing solutions. Avoid unnecessary IV fluid administration in this phase because you can have a resultant fluid overload later. In rare instances, patients can have poor oral intake. At those times, you can use IV fluids like any other hospitalized child. However, please monitor IO. So how are we going to manage dengue with warning signs and severe dengue? So let me talk about the basics of fluid resuscitation. Here, use ideal body weight for fluid calculations. Use isotonic crystalloids to begin with. And we all know we'll use a tapering fluid regimen based on the clinical improvement. Blood products we'll use as needed, also colloids. Generally, we don't use blood products for volume resuscitation. Urinary catheterization is a very helpful procedure to guide us through fluid therapy. And goal is to optimize hemodynamics here without causing fluid overload. So if there's one tube which is very important in a child with dengue, who is having a little bit of a borderline or bad hemodynamics, is urinary catheterization. So what are the endpoints of fluid resuscitation? A urine output of 0.8 to 1 mils per kg per hour, normal blood pressure for age, a pulse pressure of more than 30, improvement in peripheral perfusion, and a steady gradual normalization of hematocrit. So I'm just going to put up two flowcharts, one for dengue with warning signs, one for severe dengue. This is something which I designed after seeing multiple WHO guidelines and some of the literature. It's basically essentially the same, just in a single chart. If there is dengue with warning sign, get baseline hematocrit and initiate fluid resuscitation with isotonic crystalloids, NSR-RL at 5 to 7 ml per kg per hour or 1 to 2 hours. You reassess, meaning you look at hemodynamics and urine output. By hemodynamics, I mean vitals, pulse pressure, and peripheral perfusion. If there is improvement in all these parameters, especially the urine output, you plan a gradually tapering IV fluid regimen and switch over to enteral hydration as quickly as possible. Suppose there is no improvement, I would recheck the hematocrit. If my hematocrit remains high, I would look for features of shock. If there is features of shock, I'll follow severe dengue with shock protocol. If there is no feature of shock, I would have to increase the fluid rates and I would reassess. Suppose when I recheck hematocrit, there is a rapid drop in hematocrit. Again, I'm going to look for features of shock. And if it is there, it becomes a severe dengue. Whereas if there are no features of shock, think if there is a lab error and look for some occult bleed. Moving on to severe dengue with shock algorithm. So when there is shock, we are going to obviously look at A, B, C, D, E. And in dengue, we are going to get a baseline hematocrit, insert a urinary catheter. If it is compensated shock, I will commence fluid resuscitation with NS or RL. Here, it's a 10 ml per kg over 1 hour. If it is hypotensive shock, I would start with crystalloids or colloids even, 20 ml per kg boluses in a shorter period. And I would reassess always. And then I may have to consider blood products depending on the hematocrit. And then I would slow down the rate of fluids as the hemodynamics improve. I would send baseline investigations, do point of care ultrasound, correct temperature and metabolic abnormalities, reassess. Here again, if there is improvement in terms of hemodynamics and urine output, we are going to plan a tapering IV fluid regimen. If there is no improvement, you're going to review the baseline hematocrit which you took. And if it is high and the shock is unresolved, you would consider a second bolus of crystalloid or colloid at the same rate, 10 per kg per hour. And if there is improvement, plan a tapering fluid regimen. Suppose at any point of this time, you're not having good improvement, please recheck the hematocrit. Depending on the hematocrit, if it is low or low normal, meaning suppose somebody has a disproportionately severe shock and even the hematocrit is 40 to 45, it may mean that the hematocrit has overshot to 50 or 55, and from there the patient has bled, and therefore at this point of time it is worth considering PRBC rather than just giving crystalloids or colloids. So that is something we have to review frequently. Suppose if there is a baseline hematocrit which is low straight away and the shock is unresolved, we need to consider occult or overt bleed. We need to look for the source of bleed so that local bleeding control measures can be taken, and we can give urgent PRBC or whole blood transfusion. So this is about the dengue with warning signs, and this one is about dengue, severe dengue fluid management. So what is the role of colloids? An often asked question. I would use it in a hypotensive shock when the pulse pressure is less than 10 mm of mercury, when there is recurrent shock, when there are high rates of fluid requirement after 20 to 30 mils per kg of crystalloids. So when I give colloids, what is that I'm looking for? What is my desirable endpoint? There should be improved perfusion and urine output. And most importantly, there should be an ability to dial down fluid rates. Suppose I'm giving fluids at 10 per kg per hour. If my colloid is working, it should be able to come down to 5 to 7 mils per kg per hour at least. And you would look at widening of pulse pressure, decreased hematocrit, no worsening of respiratory status. Because when we give colloid, that can leak and cause worsening effusions and distress, or it can work too much and actually draw in a lot of fluid in the intravascular compartment and cause pulmonary edema and worsening respiratory status. So respiratory status is something that we need to watch out. So, but these are the desired endpoints with an improved perfusion and urine output. So, so far I've covered DKA and dengue. So moving on to burns fluid management. So burns, if there is a percentage of burn surface area, more than 15% patients develop systemic inflammatory response syndrome. And these are patients who will need IV fluid resuscitation to prevent burn shock, because lesser degrees of burn surface area do not go into usually SIRS. And why we need IV fluids, if this is the percentage, is because oral rehydration will not be enough to catch up with the burn fluid losses. So, and under and over resuscitation can cause increased morbidity and mortality. So how am I going to give fluid volumes? The formulas that we all know, like Parkland formula, are only to guide initial fluid resuscitation. We can titrate further based on the target endpoints. And also we need to remember fluids that have been given in other healthcare facilities, and those should be subtracted from our fluid calculation. So there are many formulas, adult, pediatric, each one likes different one. Parkland is the most commonly used. Parkland usually traditionally is 4 per kg per percentage total burn surface area. But the latest guidelines and most of the adult literature also says, including trauma life support 2018 guidelines, for adults and children more than 14 years, it's 2 per kg per percentage burn surface area. And when I say percentage burn surface area, it's second and third degree burns only. And in children less than 14 years, it's 3 per kg per percentage burn surface area. Again, second and third degree burns only should be included in this calculation. For children, we need to add glucose-containing maintenance fluids if it is less than 30 kilograms. And half of this calculate volume must be administered over the first 8 hours from the time of injury and the remaining half over the next 16 hours. And what are my endpoints of resuscitation? The most important thing is my urine output. If the child is less than 30 kg, 1 per kg per hour, more than 30 kg, 0.5 per kg per hour, and permissive oliguria is what we are looking at. So, and the patient should have normal hemodynamics and peripheral perfusion, lactates, base deficit, venous ads in those patients with central line. So these are the other things to look at, but this is the most important. Again, heart rate and sensorium may not be normal in those patients due to pain. So they are not reliable. So few burns, which is more than 40% burn surface area, may need advanced monitoring tools like echo, ultrasound, CVP. If there is high IV fluid requirement without clinical improvement, we need to look at complications of over-resuscitation like in dengue, which includes abdominal compartment syndrome, effusions, myocardial dysfunction, volume loss due to occult injuries, neurogenic shock, decreased vascular tone due to toxins and cytokines. So we need to review our strategy. So what is the choice of fluids? In general, again, it's crystalloid. RL is the preferred crystalloid here, which is good because the chloride content is again low. And here we are looking at large volume resuscitation. What's the role of colloid? It's a controversial debated topic. There are few who advocate use of colloid in the last decade, which is aimed to minimize the fluid requirement and associated complications like compartment syndrome. Generally used in the first 24 hours, but usually after 8-12 hours after the injury. Albumin is the preferred colloid, no role for dextran, starch, or FFP. So to summarize, use isotonic crystalloids RL, consider albumin if the volume requirement is high, add dextrose to the maintenance fluid in children less than 30 kilograms. So just a quick scenario, if you have a 10-kilogram child with 20% burns, second and third degree, resuscitated already in some other place with 200 ml fluids, has come after 4 hours. How do we give the fluid prescription? So for want of time, I'll just give the answer. So it's 3 per kg per percentage burn surface area, which is 3 into 10 into 20, which is 600 ml. We are planning as RL, 300 ml as the first 8 hours and next 300 ml as the next 16 hours. Already 200 we have given over 4 hours. So only 100 ml needs to be given in the next 4 hours and 300 ml over the next 16 hours. And this is a small child. So I would give some maintenance fluids with dextrose as well. I would monitor a urine output. This is a 10 kg child. I would just want 10 to 15 ml per hour of urine, not more than that. If it is more than that, I would come down. If it is less than that, I will go upon the IV fluids. So moving on to smaller topics, severe acute malnutrition, fluid therapy. So SAM with severe dehydration, usually it is oral rehydration that we do. If there is a child, SAM child with shock, those are the ones who need IV fluid therapy. How do we diagnose shock in these patients? Lethargic or unconscious and has cold hands plus low capillary refill of more than 3 seconds or a weak or fast pulse. So this is from the Ministry of Health guidelines. So if there is shock, I would do the usual measures, including temperature control. First, I would correct hypoglycemia. Then shock management is 15 mils per kilogram or 1 hour of RL and 5% dextrose or half NS with 5% dextrose, which is your half DNS, which is easily available for us, or plain RL. So this is what we are going to give in the first hour. And then what are we going to monitor? Measure the pulse and breathing rate at the start and every 5 to 10 minutes, not at the end of 15 ml per kg. I'm going to monitor every 5 to 10 minutes. What am I looking at? Look at pulse rate and respiratory rate. Look at signs of improvement. If there is improvement, repeat a fluid bolus 15 per kg over another hour and monitor again, and then switch over to oral rehydration using ORS. If there is no improvement or there is worsening, that is your pulse rate and respiratory rate increases, please stop the infusion and reassess. And then here we need to assume that the child has septic shock and we have to switch over to 4 per kg per hour of maintenance fluids, review antibiotics, start dopamine, and initiate refeeding as soon as possible. So this is about SAM. So moving on to acute kidney injury. We all know fluid management is very tricky here. So assessment of volume status is the first step in all patients with AKI. How am I going to know? By the clinical context, like is there a history of losses or is there some nephrotoxic drug or some inherent renal disease? Look at laboratory parameters. See, pre-renal causes obviously require volume resuscitation. The quantity of the fluids, rate of fluids and type of fluids is debatable. In general, crystalloids are the fluids of choice. Balanced solutions may be preferable due to tubular injury, which can happen due to hyperchloremia. I personally would prefer this, but it is not a must. And starch and albumin is definitely something to be avoided because it can worsen AKI. If there is established AKI with fluid overload and or oligonuria, switch over to a AKI regimen. So where you use insensible losses, which means 400 mils per meter square body surface area. This has to be replaced as 5% dextrose. Why as 5%? Because your insensible losses are usually electrolyte free. That's why we are using 5% dextrose. Your urine output is to be replaced as half NS, which can be modified according to the serum and urinary sodium. So this is the initial prescription that you would do. And this essentially, when you give insensible plus urine output of the previous hour or the previous 4 hours over the next 4 hours, then you are not overloading the system. What is lost is what is given to the patient. So that way you are trying to maintain a U balance in the child and you are preventing underhydration or overhydration. Also, if there is any other losses we need to replace, of course, if there is an established AKI, you need to consider dialysis. Few other miscellaneous stuff. So what will I do? How will my fluid prescription change if I have a traumatic brain injury patient? Fluid has to be restricted because I don't want my cerebral edema to worsen. So use 2/3 maintenance, which is about 50-60%. So NS or DNS is the fluid of choice. Please do not give colloids here and aim a sodium of 140 to 150 because lower sodiums can potentiate cerebral edema. So how am I going to achieve that? By fluid restriction or by giving hypertonic saline. Please monitor fluid balance. Both over and underhydration can be deleterious in these patients by causing worsening cerebral edema or worsening hypoperfusion respectively. Avoid hypotonic fluids and hyperglycemia. Again, these are things which are going to potentiate secondary brain injury. So what will be my strategy in respiratory illnesses like bronchiolitis, asthma, and pneumonia? So I would again start with probably DNS or NS depending on the sugars. Here, I would fluid restrict for 2 reasons. One, these patients are prone to SIADH where they have water retention. So I wouldn't want to give more fluids. Again, in any respiratory illness, keep the patient dry should be the norm. So I don't want to give also more fluids, okay? So that I can get the patient off the illness and move her out of the ICU or discharge sooner. So I would use fluid restriction with these fluids. So cardiac failure, again, fluid restriction, we all know this, 50 to 75% maintenance, and we would aim a negative balance. What about pancreatitis? It's a condition where there is significant SIRS and there's a lot of capillary leak. So I would use 100 to 150% fluids. I would titrate the fluids to hemodynamics and urine output, again, isotonic fluids. What will I do in rhabdomyolysis? Here again, the rhabdomyolysis is going to cause elevated myoglobin, and that's going to be damaging to the kidney. So I want to flush out the myoglobin through my kidney. So I would use high amount of fluids and target a urine output of 1.5 to 3 mils per kg per hour. So this is what I will do. Again, I would use isotonic fluids. Post-op patients, neurosurgical, they can have varied problems. They can develop SADH, they can develop diabetes insipidus like in craniopharyngioma, and some of them, very fewly, sometimes they can have cerebral salt wasting. If it's SADH that you are, you are assessing and diagnosing, you have to fluid restrict depending on what the condition, underlying condition is. Most neurosurgical patients will have only SADH. Say if it is a condition like craniopharyngioma, it's probably diabetes insipidus you are going to deal with. You are going to assess and find out. How am I going to manage the fluids? Initially, I would stick to this regimen of urine output plus insensible water losses so that I would not overhydrate or underhydrate these patients. And cerebral salt wasting needs rehydration with 0.9% saline. So lastly, thoracic surgeries, again, they are all at risk of SADH. So I would fluid restrict. If it's abdominal surgeries, they usually need higher maintenance. They have a lot of inflammation in the bowel and peritoneum. So they would need higher percentage of maintenance fluids in the immediate post-op period in the first 1 or 2 days. And then you can gradually come off. Here again, I'm going to titrate to hemodynamics and urine output. To summarize, fluid requirement is variable in different clinical situations. Understanding the underlying pathophysiology helps in determining the fluid prescription, be it the type, volume, or the rate. In general, crystalloids are the initial fluid of choice. The adequacy of hydration in various scenarios can be assessed by the following. In DKA, probably it's the sodium trends is one thing I would want all of you to remember and go from this talk. In dengue, it's urine output. In burns, it's urine output. In SAM with shock, I'm looking at pulse rate and respiratory rate. In AKI, it is a urine output and fluid balance. In general, if I have to look at any patient about fluid and electrolyte balance, especially the sodium, I would look at the urine output, sodium trends, fluid balance trends, and they are the friends forever. So look at these three things in succession. You will always get it right, almost always at least. Thank you very much for the wonderful opportunity. Thank you very much.
It was an excellent session, Priya. Thank you, Dr. Sashidharan and Dr. Priyavardhini for really finishing it on time. And literally, I was amazed by the way Priya covered all the emergency situations in pediatrics and what is the fluid therapy. Thank you very much. Now, Nisha, can you carry on with the question and answer sessions?
Sure, ma'am. I'll do that. There are a few questions. So, some I think Dr. Sashidharan has already answered in the chat. I'll start with the one that is. So, there's a question that says, are there any separate guidelines for resuscitation for severe thinness for age more than 5 years?
Priya.
Yeah. So there's nothing that I've come across. See, but you understand the principle, right? If they are undernourished, basically your assessment of hydration status is going to be troublesome. And they are going to have a total body sodium load, which are high, and they are probably going to have some edema and there's going to be some AKI. And so whenever you hydrate, you start with slower volumes with lesser sodiums and then go titrate further depending on the response. That's what I would think. Sashi sir, do you have anything else to add?
I think that's a fair way in which we are going to do. So basic principles will remain the same. So in DKA or hypernatremia or a severe thinness or obese child, the denominator is same. Your hydration assessment is difficult. So you are going with the empirical start point. Based on the response, you are going to titrate. This is the one line which will stand true.
Did you make any mention about Resuscitation, Priya? I don't know whether I missed it.
No, ma'am, I didn't mention that. No, I didn't
Yeah.
mention that. It comes in oral rehydration. It was just extending. So I just restricted myself to IV fluid therapy. So whenever we talk about oral rehydration, that is the fluid of choice, basically. And preparation guidelines have been given in all the standard guidelines, how to prepare that basically with our existent ORS.
The general comment is in SAM, IV fluids are given only if there is shock. That is, as far as possible, we try to give Resuscitation. Resuscitation is what do you say, UNICEF or WHO advised solution. We can prepare. We do have commercial equivalents to them also. So we don't in SAM we avoid IV fluids unless there is shock. Usually, thank you. Yes, Nisha.
There is a question that says cause for narrow pulse pressure in dengue. What could be the cause for narrow pulse pressure in dengue?
This is to Dr. Sashi.
Okay.
No, okay. Both of you can.
So there is capillary leak. See, it is like your diarrhea dehydration. Basically, when there is volume depletion, pure volume depletion, generally you have losses. So your body compensates by increasing your sympathetic drive. So your systemic vascular resistance increases, which means your diastolic blood pressure goes up. So the pulse pressure usually narrows down. That is your compensatory mechanism. So as you fluid resuscitate any form of hypovolemic shock, you will find widening of pulse pressure. That's the corollary.
Neonatal fluid choices.
Sorry. Yeah. Basically, neonatal fluid choices, we purposefully didn't include that. So what you need to know is neonatal fluid choices are completely different. Whatever we have shown is applicable as per the current IAP guidelines from 28 days of life onwards. That too, I would say in the term baby. Okay. So that is where it can happen. If you see the evidence base, even from 28 days to 6 months, the evidence is poor. 28 days to 3 months, the evidence is very poor. Okay, when we come in this background, you can understand what happens in neonate. In neonate, basically the hypotonicity is sometime the requirement because of the electrolyte requirement, which is completely different in the neonatal population. Second thing is their urine is more dilute. Why? Because their tubular maturity will take further time. So because of these two reasons, the hypotonic fluid usage is relatively common in neonatal population, and it has its own justification. That's what I could say. But beyond 28 days, you can follow this. But you always remember up to 3 months and 6 months, the evidence base is poor. Okay, it is kind of a borrowed evidence from the elder children.
I think that's all the questions in the chat box. Anybody else would like to unmute and ask questions? Please feel free to do so.
Yeah. Okay. Thank you. Thank you, Dr. Sashidharan and Dr. Priyavadri for really excellent sessions. It was a very practical session and it's really going to be useful to the practitioners and to our postgraduates. Thank you so much. I'm really grateful to both of you for having completed the talk on time also. That is the success of any program. Thank you so much. Have a good night. Thank you.
Thank you.
Thank you, Nisha,
Thank you.
for
Thank you.
coordinating the session. Thank you. We'll meet in more such programs in future. Please, all of you, I request all of you to register for our Marina Pedicon, which is going to happen on October 6th in Hotel Savera. Thank you all. Good night.